So the impact of next-generation sequencing on familial cancer diagnosis. I know when everyone all of a sudden sees familial, they think that this is something less common and not rare and not going to potentially impact their practice as much. But as we know with the story with BRCA1 and 2, that's not so much the case, especially in gyne-onc practice. And I'll show you how it's not so much the case across a lot of cancer types. So today, in this part of the section, I'll be discussing the current molecular methods of diagnosis in patients with familial cancer, including the role of panel testing, which I'm sure people have become aware of now, and to discuss the identification of variants of unknown clinical significance. And these are a problem in the clinic, and I know they create a lot of anxiety, not only for the patients potentially, but for the clinicians who identify these. And also to discuss the future of genetic testing in familial cancer screening and diagnosis. So if you've got 20 patients with a cancer diagnosis, invariably one of them, at least one, will have a familial cancer susceptibility. And this number is, I could have actually boxed 2 individuals there. So we've talked about nicely this idea that cancer is an accumulation of mutations, basically. So it's a disease of your genome. And basically, this just shows a normal cell, and over time, there's the acquisition of mutations, and within there, in different branches of the tumor, you can get different mutations develop, and so there's definitely heterogeneity within tumors. So why is this important? Well, in the sporadic cancer, these are acquired mutations. However, in hereditary cancer, you could consider it that the initial mutation was one that you were actually born with. And so this makes it a lot easier. We've heard about tumor heterogeneity and trouble targeting mutations. However, right here, we're talking about the driver mutation is the dominant mutation that's present in all the subsequent clones. So when we think about cancer predisposition, if we were to sequence everyone here in this room, we'd all have variation in our genome, and we all have millions of bits of variation. And when we think about how we've identified cancer predisposition in the past, so BRCA1 and 2 were actually identified from candidate gene linkage studies, so looking at these families with lots of cases of cancer and testing the affecteds for the common regions and then sequencing the genes within them, and they found the candidate mutations across. There's also been genome-wide association studies that identify basically genetic variation that predisposes to smaller amounts of risk overall, however, not necessarily significant amounts that you would see with BRCA1 and 2. And this being the rare variation over here, which you can see in BRCA1 and 2 and other genes, and it's usually private, more within families, whereas the common variation over here, which you can see across sort of various population sets. So next-generation sequencing has actually opened up the door to identify this type of variation. So one that's not it can in some cases be not extremely rare, and that have moderate effect or moderate penetrance. And so these are really quite tough now, because on the gene panels, when we do hereditary cancer testing, it has BRCA1, BRCA2, but it also has these other genes that have been classically found to be moderate penetrance. And actually, PALB2, I'm glad that it was raised because it was initially identified as a moderate penetrance gene. However, in these subsequent studies, looking at these high-risk families and circumstances, it does give you a risk that raises to the level of having a BRCA2 mutation in certain families. And so this is important because it means if we see variation in these genes, we have to know how to actually manage these families as well. So this is generally what we show patients. However, it's not always quite as clear-cut as this, but most of the time we say that the majority of cancers are sporadic, and it's just in 5 to 10% where we can really pinpoint a genetic lesion. In this familial subset, this is where there's a combination of sort of genetic and environmental factors, and probably a lot of those lower-risk SNPs. So this is the obligatory genome photo I see now. So this is the old school way of showing it, but here we have, say, a mutation in BRCA2 in an individual. And what's important to understand, if this is just a single cell here, it's a consideration that this is the picture in every cell of that person's body, where one copy of their gene isn't functioning. And this is probably in the general population, maybe about 1 in 300, 1 in 400. I guess that's important just to recognize that this gives rise to potentially multiple primary cancers, because if we're thinking about Kaminstan's two-hit hypothesis, if cancer is a disease of acquiring mutations, you've got a greater chance of developing a mutation, a second hit in your other normal copy. So people get multiple primary cancers, they get early onset, and there's a risk because they carry this in their gonads to pass it on to the next generation. So when we talk about ascertainments, typically we've done them based on looking at the family trees and basically looking and seeing multiple affected individuals and those features that I said people develop, but also based on tumor phenotype. So we know that mismatch repair deficient tumors now, we basically test the germline of those for Lynch syndrome genes, all invasive epithelial ovarian cancer and triple negative breast cancers under age 60. We also use risk prediction models, and generally there are provincial guidelines that people have. These are the BC Cancer Agency referral criteria, and we have about a 12% mutation detection rate using these. So the current molecular methods of diagnosis include site-specific. That's when you've got a family and you know the mutation. It's carrier testing. It's also if you know a person comes from a founder mutation. So you can test for, say, the BRCA1 or 2 Ashkenazi Jewish founder mutations. There's single gene sequencing, where we test the whole gene, and then panel sequencing. The exome sequencing and genome sequencing is more on a research basis at this stage. So here are the Ashkenazi Jewish founder mutations. Why it's important is because if BRCA1 and 2 mutations account for this proportion in the general population, not of Ashkenazi Jewish origin, 5 to 10% in early onset breast cancer and 15 to 20% in ovarian cancer, it's more significant when you test an individual of Ashkenazi Jewish origin. So the possible results, here they are. It's basically an uninformative result is the most common result we get, just because I told you our detection rate is basically 12%. We have a 10 to 15% detection rate of actually finding a likely pathogenic or pathogenic mutation, and a variant of uncertain significance for just BRCA1 and 2 is around that 5 to 10% mark. So multiplex gene panels, I think everyone's probably heard of them. There's lots of companies that are out there selling them, and they basically need a physician as well to order them. And so they are here, and they are running hundreds of thousands of tests per year. So what are the pros? They decrease the diagnostic odyssey. It's much faster. Sometimes we see unexpected diagnoses that impact management. We've had a couple cases where there's been germline P53 mutations in high-grade serous. Had another one where we were testing for the index indication of hereditary breast and ovarian cancer in an endometrioid ovarian cancer, and it was underlying MSH6 mutation associated with Lynch syndrome. Not necessarily unexpected, but it wasn't the indication that we were testing it for. But has significant management implications. So the cons, well, it increases the number of variants of uncertain significance, and also moderate penetrance genes are on there for which we don't have extremely strong management recommendations or experience. So just the experience in the hereditary cancer program in a population-based clinic, 14 gene panels testing only affected individuals ages 19 and over, meeting criteria. So this panel includes multiple syndromes, 9 of them. And so just the main thing to understand is the majority, 85% of our tests are for hereditary breast and ovarian cancer, about 13% are for Lynch syndrome. So of around 400 individuals who have had results today, 12% had the positive findings, 2% were monoallelic for MUT-YH. MUT-YH is associated, it's a recessive syndrome, MUT-YH associated polyposis, and there's a founder mutations in the European population in 2% of individuals. So the frequency of positive findings, most had just one mutation, but 3 individuals had two mutations. So what I want to show you is actually the rate of variants of uncertain significance in this subset. So there were about 40% of cases had variants of uncertain significance, and this is basically the way we counsel patients, is that they need to understand there's a high rate of finding something that we will have difficulty in interpreting now, and they'll need to come back to us in future. So there were individuals that had multiple variants of uncertain significance. The breakdown of these are, they were in BRCA1 and 2. However, there were certain genes that were more classic to find variants of uncertain significance in, and MSH6 and APC were part of those. So the actual results again, so unexpected findings I mentioned, like the P53 in the ovarian cancer, was 1%, variants of uncertain significance 40%, and then these monoallelic MUT-YH mutations in 2%. And I say that because these are included on some panels, and the question is, how do we screen those individuals, and is there any risk associated with them in the heterozygous state? And the jury is still out, although most cases, it depends on the family history of colon cancer. So where do they come from? They're usually rare by definition from how we classify them. They're mainly inherited, and we all carry them. So you get more if your ethnic background is less well represented in the public databases, simply because we just haven't seen it before. So what makes them worrisome is that they have been identified in these biased circumstances where you're actually looking in that particular gene. I'll tell you that most of them get reclassified as benign in the future. However, there are some that do get upgraded to pathogenic. The issues with them is what do you actually do with them? Well, we need to look at them more closely and submit them to efforts that help characterize them, like the Enigma, which is one that looks at them closely. It's a group of basically PIs from all around the world who look at them in various levels of evidence with regard to them. Really important that these are submitted there. The reclassification requires evidence of pathogenicity. So the ACMG, American College of Medical Genetics, they have criteria around variant classification. And a lot of that criteria that you would need to actually reclassify these would be in segregation analysis or functional studies. We don't do any actions on the basis of them, and that's really important. It's important because you can't infer that it's just pathogenic just because you saw it in the right circumstance. And so we don't offer carrier testing to family members because we don't want family members to act on it, and we don't want them to not act on screening because they don't have it, basically. In certain circumstances, when there's enough people in the pedigree or family, we will offer carrier testing looking for segregation analysis. So some companies will say that they will do further studies on a variant, and they'll usually put that in the report. So efforts to follow VUS, there's one major one at the moment. This is a prospective registry of multiplex testing, and this is actually trying to capture all the VUS and all of the other genes as well that are included on panels that people find out of context. This is something where patients can directly go to on online registry, and then they can further go on to participate in further studies to learn more. So lastly, what is the future of genetic testing of familial cancer screening and diagnosis? Well, tumor normal sequencing. We've talked about it a lot today. And actually, it's important to understand, yes, we're looking for targeted therapies, but as you've heard, a lot of the therapies relate to also germline variation, like the BRCA1 and 2, and the effects of it. So there was a recommendation initially about the American College of Medical Genetics and Genomics put out back in 2013, and that was actually when anyone was undergoing any sort of clinical sequencing, that there be actionable variants, so presumed pathogenic variants in a set list of genes reported back to patients. And this was any sort of clinical sequencing, but they had one sentence in there that said it included the normal of tumor normal sequencing, which was something that people hadn't really looked at or addressed what the actual burden would be in the cancer setting. So we did this study, and this was through Sloan Kettering, to actually look and determine the burden of presumed pathogenic variants in patients undergoing the tumor normal sequencing. And we studied over 1,500 cases, and this was all sorts of tumor types, basically. There were about over 68 in total. So this was basically a gene panel, 341 genes. You can probably find your favorite gene on there. This list was created from the MSK, basically researchers who were interested in certain genes and pathways. It was also created, it was somewhat loaded for germline susceptibility genes. And what you see is actually the full list there. In pink is actually ones that are associated with OMIM or Mendelian disease genes. So these are single gene disorders. And that's over 55% of the gene panel, which is important in terms of understanding biology in cancer cells. The same genes that were important in embryogenesis are also important when they are mutated in the cancer setting. And so circled in red are the cancer genes, or ones that have been associated before. And these include all types of inheritance, so dominant, recessive, X-linked in there if they have association. In blue are the ACMG overlap genes. So the summary of the results is essentially that 16% of cases, so this was just looking at what happened when you sequenced all those 341 genes. It was just focusing on the 187 OMIM genes, or Mendelian disease genes. 16% of cases had an underlying presumed pathogenic variant in them, which is, interesting to think about. In terms of the cancer susceptibility genes, looking at dominant and also recessive conditions, almost 13% had an underlying mutation. Of the ACMG genes, it was about 6.4% if you included the monoallelic MUT-YH carriers, 5% if you didn't. This information's published, and so you can see it. I guess one other interesting thing to point out is that there was a 1% rate of also seeing somatic mutations that looked like they were more from the blood and probably an incidental hematopoietic clonal neoplasm unrelated to the tumor. But in here, it just breaks it down. Of these high penetrant genes that were included in the ACMG list, it was about 5%, increasing to up to 7% for ones that would actually be clinically actionable. And this was across all tumor types, unselected for family history. So there were variants of uncertain significance when you considered all of the 187 Mendelian disease genes in total. So these cancer and ACMG are just subsets of this Mendelian number in basically all of the cases. And so when you looked at 187 genes, everyone virtually would have a variant of uncertain significance. If you just restricted it to the 93 cancer genes, it was still very high. Just restricting it to the 26 ACMG genes, 50% had one. So you can see this has significant implications for labs wanting to report this out. In terms of evidence for what was the relevance to the tumor, so you could argue, were we just doing back-end population screening? It's possible, and that these didn't have relevance to the tumor, but most of the time the cancer susceptibility ones were actually retained in the tumor, and there were cases we could prove that there was good evidence maybe in 20% for a second hit, and there was an unexpected phenotype in a third of those cases. So I just show you this slide to show, when we think about BRCA1 and 2, we think about breast, ovarian, pancreatic, and prostate cancer, but here was gastric cancer that stood out. There were 5 cases within this cohort, 3 of which had loss of heterozygosity. There were also a number of sarcoma cases that had basically an underlying BRCA mutation. So this panel isn't, we didn't look at sort of the mutational burden within it, but you could, envision a study later to actually say what was the functional significance of these and can it correlate with increased mutation burden. So here we have now that you need to consider the germline aspect when considering tumor normal sequencing, and that's because this is a driver mutation in some of these cases, and here are some therapies that are relevant in this regard. So clinical implications, consent for panel tumor sequencing should involve a discussion regarding the potential to reveal genetic information that may have broad implications, and labs will need to be aware for the significant burden of variants of uncertain significance. So in the hereditary cancer assessment, basically, so this is usually what ends up happening. We see these families this is a pedigree, the black filled in ones are the affected individuals, circles are the females, squares are the males. Here we see this one has a tumor that got mismatch repair deficient, and this individual here has a mismatch repair deficient tumor as well. Well, if we now assess them and consider, say we're going straight and doing tumor and normal DNA sequencing on the tumor and also on the germline, this is another avenue which we can basically see these patients in clinic when they're identified in this setting. Okay, so the familial ascertainment, tumor phenotype, now we have to think about tumor sequencing. So, and this is, to me, this is the obvious answer is, we've done all these assessments based on what we think it looks like, but now we can go straight to the tumor and see what it was. And so I think about this, and it's almost analogous to when we were listening to heart sounds and then we get the echocardiogram. So I think this is going to significantly impact the way that we assess these families, because all of a sudden we can see which ones look more likely to be somatic, where they can be explained and there's no germline information. So this person gets sort of taken out of the familial assessment, whereas, and same in this scenario, Whereas in this case, this is, we continue on with the familial and germline assessment, basically, and give them at risk because we know the information up front. So here, we continue on the right to continue to see them, and then on the left, we probably cool off and maybe can say that they've got more population risks. So main messages, gene panels are here. Variants of unknown significance are common. Tumor sequencing will change the way we assess for hereditary cancer. And if you only take one piece of information from this, it's probably this last point here, is that consent for tumor sequencing should include a discussion regarding the potential to reveal germline genetic information. And that's it.